Hello students, we will discuss an image study today which is very important. What this image is, look at that entire image, look at the radiolucent area, look at the radio opaque area. So what this image is and what is the finding. So it is ultrasound abdomen showing gallbladder with the stone. You can see the stone here. This is the gallbladder, this is the stone, this is the stone. So remember, ultrasound is a very sensitive investigation for gallbladder stone, whereas a CECT abdomen is sensitive investigation for CBD stone. Ultrasound is more sensitive than CECT for gallbladder stone, but ultrasound will miss CBD stone definitely many times. It may pick up, may not pick up. Otherwise, MRCP is the ideal investigation. Ultrasound is very sensitive investigation for gallbladder, very specific gallbladder stone, not CBD stone. For CBD stone, and if you want to see the pancreas, lymph nodes, then CECT abdomen is ideal. If you want to see the only lumen and identify, pick up the suspicious stones, even after CECT abdomen doesn't pick up, then MRCP is ideal. Like that, points you should remember of different among these three images: ultrasound, CECT abdomen, MRCP. A lot of confusions about these three things. These points are very clear. And remember fat, fertile, fatty, flatulent female as a causative agent. Remember metabolic causes, that lithogenic bile, that cholesterol, that lecithin, that bile salts. That are the three components of this lithogenic bile. Infections, bile stasis, hyperbilirubinemia, limey gallbladder. Remember limey gallbladder. Limey gallbladder contains lime-like content. So they call limey gallbladder. Porcelain gallbladder. Here it is different from the limey gallbladder. It is gallbladder wall is calcified. That is porcelain gallbladder. Remember, porcelain gallbladder is a pre-malignant condition. Very high chances of turning into carcinoma gallbladder. Gallstone itself is a potentially condition where may turn into carcinoma gallbladder after a long time. Whereas porcelain gallbladder, where gallbladder wall is calcified, is very high chance of turning into carcinoma gallbladder. That is the point you have to remember as far as porcelain gallbladder. That's how it differs from the limey gallbladder. Limey gallbladder is a content, whereas porcelain is in the wall. Remember, Mercedes-Benz sign or Seagull sign, radiolucent area within the stone. Remember effects of gallstones: pancreatitis, slipping of the stone into the CBD, then forming cholangitis, ascending cholangitis, pentards, the Raynaud's pentards, then Mirizi syndrome, cholecysto-choledochal fistula, then gallstone ileus, pancreatitis, cholecystitis, perforation, pericholecystatic collection, gangrene of the gallbladder, empyema of gallbladder, different conditions, sepsis, all those things can occur. Fibrotic gallbladder, chronic cholecystitis. So many different effects can occur once there are gallstones. Rate, of course, carcinoma gallbladder still is one of the late effect of gallstone as such. So remember Murphy's sign when you examine the lower, in the right upper quadrant, on the zenith of the inspiration, patient winces with the pain. That is the typical Murphy's sign. You have to remember that. Mirizi syndrome, I said, cholecysto-choledochal fistula, 3-4 grades are 4-5 grades are there. Remember that. Gallstone ELS, whereas gallstone enters in the duodenum, cholecysto-choledochal fistula, stones pass as rolling stone from the bolus. Remember, there is a dialogue, and that bolus, narrow part is in the ileum, forms a bolus obstruction. After stones rolls up, forms a bolus forms a obstruction there, present as intestinal obstruction, gallstone ileus, in the usually ileal obstruction. So that is the gallstone ileus. All these things are different short forms for Mirizi syndrome, gallstone ileus, Murphy's sign. Clinically they will ask, oxy they will ask, short note may be there. Effects of gallstones are short note. MC questions can be asked. Etiology for gallstones are gallstones. Remember the difference between the cholelithiasis. In the main question they will ask, that is the gallstones. Choledocholithiasis, that is the stones in the CBD. Difference you have to remember always. It is a CBD stone. Choledocholithiasis is classified as primary and secondary. Secondary is the one which slips from the gallbladder into the CBD. And whereas the primary is the one where the stones occurs within the CBD. There are usually multiple extents across the right and left hepatic ducts, often into the liver, biliary tree also. There is a difficult to manage, often requires a choledocho or hepaticojejunostomy, anastomosis to have a proper cure. So this is these differences you have to remember. Choledocho is CBD stone, cholecysto is gallstone. So in question you should be very careful. You write about gallstone, if a choledocho is asked, that is wrong. Answer will be wrong. So these differences you should remember always. And management is LFT, serum amylase, serum lipase, ultrasound, CECT abdomen, MRC if required. Rule out malignancy if there is obstructive jaundice, periampullary carcinoma, head of the pancreas, or CBD stricture, or Klatskin tumor, or CBD cholangiocarcinoma, or compression by the lymph node. All those things you have to remember as an obstructive jaundice cause. And remember ascending cholangitis, Charcot striate, Reynolds pentad, and treatment strategy always. Ideal for gallstone when there are no CBD stone, laparoscopic cholecystectomy. If there are secondary CBD stone which is clipped, then you have to do ERCP. First, you have to ask medical gastroenterologist for that. Then later, after usually within 48 hours, current standard is within 48 hours, you can go in and do laparoscopic cholecystectomy, stent removal after a month, within a month actually. So that is the treatment strategy for gallstones. Ideal gold standard is laparoscopic cholecystectomy. That point also you have to remember. So gallstone is a very common question asked. So many things are asked and MCQs are asked. Remember, gallstone chapter is very, very important. So this is the multiple stones are here. You can see there are multiple stones. See that laparoscopic port placement diagram they will ask. MCQ they will ask. So you should remember. Oxy they will ask. So this is the 10 mm port for camera. 10 mm epigastric port here for dissection and retrieval of the gallbladder specimen after cholecystectomy. This is the 5 mm port for dissection. This is the 5 mm port mainly to hold the Hartmann's pouch. 5 mm port to hold the fundus of the gallbladder, so that retract the gallbladder above, so that the dissection will be very crucial. Calyx will be visualized by that, by holding this lateral 5 mm port. So dissection of the calyx is important. Both the cystic artery, cystic duct should be identified properly. Should not clip the CBD. Should be always cautious about the CBD while dissecting the calyx. It's very, very important. If you clip the CBD, with real complication of obstructive jaundice can occur, may leak also. So this is Strasbourg critical view of safety. Remember CBD is here. Remember, cystic plate should be visualized properly. There are only two structures. This is the cystic artery. This is the cystic duct. This is the CBD here. Cystic duct. So only two structures. Cystic plate should be visualized properly. So proper calyx dissection, that is called Strasbourg critical view of safety. It's very, very important, this safety view. Strasbourg critical view of safety is again MCQ question, and also Oxy they will ask, Viva they will ask, maybe a short answer question also. So clipping, see that cystic artery is clipped one side, other side bipolar cord is made and removed. This is the CBD, you can see here, and this is the cystic duct, 3 clips, 2 to 1. In between that, proximally 2, distally 1, and then you can cut. This is the Hartmann pouch is held. It is a fundus above held, 5 mm port, dissection to the 10 mm port like that. So 3 clips, 2 and 1. Between that you have to cut. 1 clip is sufficient for the cystic artery. So that is the laparoscopic cholecystectomy. That is the gold standard. Remember Strasbourg critical view. Remember this port placement. That is also very important. MC question. Maybe theory short note also they will ask laparoscopic cholecystectomy. So answer the MCQ. Saint triad is gallstones, diverticulosis colon, hiatus hernia. B. Renal stones, diverticulosis colon, hiatus hernia. C. Pancreatic stones, diverticulosis colon, hiatus hernia. D. Gallstones, diverticulosis colon, linguinal hernia. Write the correct answer. Answer them. Lithogenic bile is A. Decrease in bile salt and cholesterol ratio. B. Increase in bile salt and cholesterol ratio. C. Equal in bile salt and cholesterol ratio. D. Increase in cholesterol only. So students, put your answer please in the comment box. I will also put the right answer later. So those two MCQs are required. It's very, very important as far as learning MCQ is concerned. And please go through my clinical methods in surgery with video. All examination different chapters are covered very well. My manual surgery gives detail about everything all of you know. My Atlas 2 volume gives minor to major procedures in detail with illustrations and photos. Around 10,000 illustrations are there. My Atlas, small Atlas with studying techniques was very useful with video. My Diginor lecture covers everything for CBM in surgery. All chapters, including specialty with uploaded surgery, instruments, specimens and images. So you can always purchase through JP Publishers and for 1 year and increase your knowledge. It will be very, very useful for your exam and understanding subject as such. So students, I hope you have understood this lecture very well. Thank you very much.